Hi, everyone. I woke up early this morning to Skype with my friend in Kingston to make sure I could do this in 15 minutes, and he actually fell asleep, and he told me it wasn't because this was boring, but because he was tired, so. And I think he hears me talk about this too much anyway. I'm just going to time myself here. So in BC, we know that STIs are distributed unequally across groups of young men, with men who have sex with men or gay or bisexual identified men bearing a disproportionate burden of STIs and HIV. I won't go into all of the rates and stuff like that. I'm sure we'll see that or we have in many of the other presentations. But I wanted to go into a bit of a sociological analysis of why this might be and what's out there in the literature, and then draw from some interviews that I actually worked on over the past couple of years. Some scholars have attributed the inequities in health for gay and bisexual men to a lack of understanding between the interventions that are being implemented, so sexual health interventions, and gay culture, for example. And there's some recent work around STI testing and pointing to how, like I think what we saw in the last presentation, how a lot of clinical practice is very heterosexist or heteronormative or homophobic. So little is also known about how heteronormative sexual health practices affect heterosexual identified young men. Beyond explanations about how straight identified men aren't really able to have really meaningful connections with one another, there's really nothing looking at heteronormativity and straight men. I think we saw yesterday some interesting data from the McCreary study and from Steve Mulligan's information he has through working with VSB, that a lot of homophobic incidences are actually targeted towards straight men. In the sociological literature world, if we should call it that, this is called fag discourse, and it's basically repositioning homophobia as something far more complex mechanism that affects more than just homosexual people, but of course it affects homosexuality the most. So we know that heteronormativities and heterosexism and homophobia can hurt us all, and it especially hurts those who identify as gay. And to better understand how heteronormativities affect men's sexual health, I'm going to present a discursive analysis of the processes and practices in clinical encounters that may reproduce or naturalize heteronormative cultural assumptions and heterosexual power, both in and outside of the health sector. So with you today, I'd like to try to better understand the nuances and complexities and how heteronormativities affect young men's sexual health-seeking behaviors, and then to present an analysis of young men's discourses and clinical processes. Really want to get at how these heterosexist experiences and heteronormative assumptions can be transformed through potentially emancipatory experiences. So like I said, I'm going to draw from 48 interviews with young men. I've also got 30 interviews that I've analyzed with service providers. This is from across 5 different cities or towns and cities in BC. There's Richmond, Vancouver. I don't have the breakdown here of how many from each, but it's roughly even. Quesnel, Prince George, and Fort St. John. So quite a diverse group of communities. So from these data, several themes emerged from the data. First one I've labeled finding the other. So we know a patient's sexual behavior is a very crucial piece of information for service providers to distinguish during an STI testing clinical encounter. in order to appropriately as well as efficiently determine what to test for and what tests to run. But some youth who identified as gay or bisexual in this study explained that they had experienced anxiety related to these questions, especially when clinicians transgressed the normative cultural assumptions of heterosexuality. As one 19-year-old young man who identified as gay explained, I don't really think the clinicians have any right, really. I mean, you can volunteer, but I don't think there's any right or reason for them to know your orientation, even your activity. I mean, it doesn't make that much of a difference. The young sexual minority men that had anxieties about speaking about sexual identity and behaviors underlined the reality that gay and bisexual men are also seeking healthcare services with their own heteronormative expectations. So that is, they come with a wider set of social relations that dictate heterosexuality as the norm. And they might not feel safe saying that they're gay or bisexual. Other youth explain clinical rationale for risk assessments looking at behavior. So for example, a 20-year-old heterosexual identified male from Prince George explained, his clinician said, do you snort cocaine? Do you shoot heroin kind of deal? So needles and tubes for those kinds of activities, they put you in a higher risk group for HIV as well as taking it in the ass. I said, no, no, no. And they said, okay, you're not in a very high risk group. If you really want to be tested, we can do it, but I doubt you have it. However, there were also explanations that were conflated with sexual identity that became more problematic. So for example, 24-year-old heterosexual identified male from Vancouver explained, when I brought up HIV testing, I was asked, if I was a drug user or a homosexual. And if I wasn't, then I was in a much lower risk category and my chances of having it were seriously low. So while assessing risk based on history of intravenous drug use and anal intercourse are very important factors for determining the level of risk the individual may be exposed to in terms of HIV transmission, and I think it was also presented in the last presentation as well, systematic assessments from some physicians relating sexual identity to being at high risk, they're not effective. And they also will conflate sexual identity with risk. And some clinicians that we interviewed were overtly aware that A, young men may feel uncomfortable answering these questions, and B, they risk conflating identity to risk rather than associating the behaviors with risk during these clinical encounters. So some explain that although it may take a bit longer, that they will take a nuanced approach and just explain to the young men why they're asking about sexual behaviors. So for example, one public health nurse explained, some of these questions might be embarrassing, so we tend to explain the questions. So we'll ask, when you have sex, do you have anal sex? Somebody's penis in your bum or your penis in somebody's bum? The reason I need to know this is, and so they go into an explanation saying, this is why I need to know. And I think he makes a good point, saying it's not a polite conversation usually. For a lot of the young men in our study, they explained this was the only time we ever talked about sexuality with a stranger or with anybody, and about sexual behaviors. So his approach, or this public health nurse's approach to assessing risk, takes a perspective that appreciates that interactions within the healthcare setting are taking place within a set of wider social relations that influence patient-provider discussions. Several of the gay men in our study felt like their clinicians were not really assessing risk. For example, there was one 22-year-old gay male from Vancouver who was actually involved in sexual health, peer sexual health education. And although he had not been sexually active since his last time going for testing, and he had told his clinician this, when he went to get his results, he said, and he just wanted to go for testing so that he wasn't practicing what he preaches, I guess. Go get testing every 6 months is what he would tell the young people he worked with. And so he says, when she gave me my results in a fine manner, and then she suggested, how did she phrase it? She said, she was giving me some tips on how to have a healthy sex life and be as safe as possible. And I didn't really feel like saying, oh, well, I've been a sex educator for years. And she said, you know, some people use 2 condoms at the same time, as if this was some kind of an excellent option for me. And I said, oh, I'm sure some people do. So he was pretty overtly aware that she was conflating sexual identity to risk and not behaviors, because he was not sexually active at the time of this consultation. And so clearly we know, especially everyone here, that some of these nuances around risk and sexual identity are coming from outside of the clinical setting and are coming probably from community level or societal level social norms. And at the community level, some youth explain their everyday reality and social lives as being culturally anti-gay or homophobic. So for example, one 19-year-old heterosexual identified young man from Fort St. John explained, you're dealing with people out there that are the typical guys who would get drunk, and if they seen a gay guy, odds are they'd probably fight him. They'd pick a fight with him. Like myself, I know, like I got buddies who were in high school that turns out they're gay. I got no problem with that, so long as no lines get crossed. The degree to which these community norms were transferred and related to the clinical settings was discussed with clinicians. So we asked them, is there any homophobia in your clinic, like with your colleagues? And we talked to one public health nurse, and she explained one situation she dealt with. And she was talking about somebody who had complained to her about a poster she put up of 2 gay men embracing. She said, like, I mean, a lot of the frontline staff they're clerical, you know, and they're good at what they do, but that doesn't mean they didn't necessarily know what they were getting into when they came here. And knowing that, they may have to, you know, be aware of some issues around that. And I advertised pride and stuff like that. And she did get hate mail. And one colleague actually confronted me in the hallway at one point and said, I don't approve of you flaunting your sexuality at work. I said to her, my sexuality is none of your concern unless you're wanting to have sex with me and you're not my type. Interestingly enough, this public health nurse was not, she wasn't even gay. So, so we asked her, like, did you go to your management and talk to them about that? And she did. And so we asked, how did they respond? She said, I would have liked to have seen it being kind of an instigation of change. Like, obviously, something made them really uncomfortable. So we need to deal with that because that's not fair to them either. She's talking about the people who complained. And not have some resolution. Because, I mean, most of these people are pretty good, solid people, and they wouldn't say something like that if they weren't feeling threatened, scared, you know, something was really upsetting them on some level. And so I think management still needs to deal with that safety. That's a real safety issue, emotional, spiritual, whatever, safety for everybody. I think this is a really good example of how larger community-level cultural expectations of heterosexuality can affect clinical encounters. I think this nurse is really adept to recognize that this could have been a potential transformative moment for these homophobic colleagues of hers, but management just simply didn't respond. And so these data, I know that's not a whole lot of data I showed you, but what I did show, I think, begins to pull out some of the complexities of how heteronormative expectations come out or come into play in clinical encounters with young men. And while some of the examples don't appear to directly harm the health of young gay and bisexual men, they do provide illustrative examples of how these heterosexist discourses can be reproduced in clinical encounters and how they can be potentially transformed. this is really just a case study. I literally pulled this out of a larger, probably very boring sociological analysis that I've been working on. But I think it's important to think about how do we address these heterosexist clinical practices and heteronormative cultural expectations. And I like to think about it from macro, meso, and micro level. So when we're talking about macro, I think Ross Johnstone was doing or gave a great example yesterday with his work out in schools, going to work with kids as young as grade 5 and talking to them about what it means to be gay. Meso, clinical policy, I mean, educating your clinicians and clerical staff. And micro level, I think again, the last presentation did a very good job of saying, like, these clinicians need to know how to talk with their patients, whether they're gay or straight or whatever, right? So that's my presentation. I realize I'm out of time, but thank you.